Hello, and thank you for having me here today. My name is Crisologo. I'm assistant professor at the University of Texas Southwestern Medical Center here in Dallas, Texas in the United States. The topic I've been assigned to speak on today is regarding intramalleolar disease in patients with diabetic foot ulcers. I have no conflicts of interest to discuss. We'll start with a short case here. You have been consulted on a 68-year-old male patient in the emergency department for foot gangrene after them having recent bilateral bunion and hammer toe correction approximately 4 weeks ago. As you can see from the clinical picture here, it is not going very well. They have a past medical history of type 2 diabetes, end-stage renal disease on dialysis. They're a 2-pack-a-day smoker for 50 years, hypertension, COPD, CAD, status post-cabbage, and peripheral arterial disease. They have a past surgical history of bilateral lower extremity tibialis anterior and posterior tibial angioplasty approximately 3 years ago, a cabbage 1 year ago, and then their bilateral bunion and hammer toe correction a month ago. They have no allergies. Their vitals here, they are afebrile and stable except for their quite elevated blood pressure. You got a basic lab panel on them. They have no leukocytosis. Their SED rate is 42, CRP 1.5, and they have an A1C of 12%. This is a pretty common patient. I think a lot of us see relatively routinely. Now, this brings up wound healing. This is something that we all deal with, and it's a difficulty that a lot of our patients, if not all of them, have. These are difficult to heal at baseline. So the real question is, how long does it take to heal these wounds? What role does vascular disease play? Especially, what role does the location of the vascular disease play? As you can see here, we have an example of an angiogram here on this slide, but unfortunately, that angiogram is not like the one this patient has. This one here is much closer to what they probably have. Going on to wound healing, this is a classic article that I like to discuss with our trainees. This is a common question I get from patients. How long is it going to take for my foot to heal? This is an article by Peter Sheehan, Diabetes Care in 2003, looking at a 4-week wound area reduction and its ability to be a predictor of healing over a 12-week time period. So they found that patients who did have a 50% wound area reduction in 4 weeks had a slightly better than a coin flip's chance to heal in 12 weeks, but if you did not reduce your wound size in 4 weeks by half, they only had a 9% chance of healing their wound in 12 weeks. So this is something that I think we all think of or deal with when we're consulting our vascular colleagues. If you're not a vascular colleague yourself, is are palpable pulses enough? This is a question that comes up a lot in our institution. We have maybe the vascular intern or resident come evaluate the patient, say they're palpable, we're not doing anything, but that doesn't necessarily correlate with the outcomes that these patients have. This is an article by Forsyth et al., also reference one by Vranz et al. From 2020 and 2018 respectively, looking at the effectiveness of bedside investigations to diagnose peripheral arterial disease in these patients. This first one by Forsyth is a systematic review, and they showed that ABIs, or ankle brachial indices, do a better job of ruling in but not ruling out vascular disease. For example, they found that if you have an ABI of less than 0.9, has a positive likelihood ratio of 6.5. An ABI of between 0.9 and 1.3 has a negative likelihood ratio of 0.31. TBIs were a little bit more valuable. Those greater than 0.75 correlated with a reduced risk of PAD with a negative likelihood ratio of 0.14 to 0.24. But triphasic tibial waveforms were the best for excluding a PAD diagnosis with a negative likelihood ratio of 0.09 to 0.28. The ability to palpate pulses, a negative likelihood ratio of 0.75 with a positive likelihood ratio of 1.38. Many articles have been written on the Wi-Fi score by the SVS, and the Wi-Fi being wound, ischemia, and foot infection. This is one by Jean et al. In 2015, correlating the Wi-Fi score with a risk of major amputation and time to wound healing. This is impressive because they had 201 consecutively enrolled patients, and each one had at least a 2-year follow-up. 42 or 21% of these patients required a major amputation, with that being defined as either a below-knee or above-knee amputation, and 78% or 159 had limb salvage or did not require that higher level amputation. They showed that in stages 3 and 4 of Wi-Fi that there was a higher incidence of amputation, as you can see to the figure on the right. There's a decreased amputation-free survival. There's also a delayed wound healing time. Going a little further into the comment on the wound healing that they noted earlier in this article, they showed with this survival curve here, the healing time is greatly impacted by the patient's PAD level. You can see on here those various Wi-Fi 1, 2, 3, 4. With someone that's a Wi-Fi 1, average time to healing 95 days, roughly 3 months. If you're a Wi-Fi 2, 115 days. Wi-Fi 3, 163 days. Finally, a Wi-Fi 4 of 263 days average time to healing. This is an excellent article headed up by one of the other colleagues here at the conference, Dr. Liat, looking at a prospective analysis of this SVF's Wi-Fi classification system, stratifying immediate and 1-year patient outcomes. This is a bit of a busy slide, but I want to draw your attention to a few areas here. First, looking at surgical wound dehiscence. If you look, Wi-Fi 1 or stage 1, none of these patients, although there were only 14, had it, and it really increases as you increase the stage. Wi-Fi 2 had almost half, 47.8%. Wi-Fi 3, 71%, and a Wi-Fi 4, 84% of the patients. This is an excellent article headed up by one of the other colleagues here at the conference, Dr. Liat, looking at a prospective analysis of this SVF's Wi-Fi classification system, stratifying immediate and 1-year patient outcomes. This is a bit of a busy slide, but I want to draw your attention to a few areas here. First, looking at surgical wound dehiscence. If you look, Wi-Fi 1 or stage 1, none of these patients, although there were only 14, had it, and it really increases as you increase the stage. Wi-Fi 2 had almost half, 47.8%. Wi-Fi 3, 71%, and a Wi-Fi 4, 84% of the patients had a wound dehiscence. Subsequent proximal amputation, those who went on to a below or above knee amputation, once again, Wi-Fi 1, none of these patients did. Wi-Fi 2, 1, Wi-Fi 3, 4 of the patients, and Wi-Fi 4, 15 or 1/3 of the patients ended up with an amputation. And soberingly enough, death was also a significant finding as the Wi-Fi stage increased. About 23%, almost a quarter of the patients in the study died in a year. Only one of those was from Wi-Fi 1. 5, or about 20%, was from Wi-Fi 2. Interestingly, Wi-Fi 3 only had a 10%, but Wi-Fi 4, 40% of the patients Hicks et al. In 2018 further took the Wi-Fi classification, showing that it independently predicts wound healing in patients with foot ulcers. They had 310 patients with 709 wounds, and they showed that, as you would expect, increasing Wi-Fi stage correlates with poorly healing wounds. Likelihood of healing in a 1-year time period, if you're Wi-Fi 1, 94%, Wi-Fi 4, 67.5%. Darling et al. In 2016 in JVS also looked at the SVS Wi-Fi classification system, but this time following infrapopliteal endovascular interventions for patients with CLI. They showed that it didn't maintain its predictive value in patients who had these infrapopliteal interventions. They broke it down into a 0 to 9-point composite score to try and predict these outcomes, looking at wound healing, reintervention, major amputation or stenosis events or RAS events, amputation-free survival, and major amputation. As you can see here, this is how they took the Wi-Fi system and broke it down. I won't read it to you, but this is available if you want to look at it further later. And they showed that a 1-unit increase in the Wi-Fi composite score was associated with a decreased wound healing, RAS events, and major amputations. You can see in this curve they took the DFAC composite of a 1 to 4 or a 5 to 9, showing that yes, there was a difference in patients' freedom from amputation over a 1, 2, and 3 year time point. So when we look at inframalleolar disease, how do we classify the pedal flow? And this is a really nice depiction of the Cairo classification of the pedal arch. We have on the far left type 1 having both dorsalis pedis and the plantar arteries patent. Type 2A, next one over, only the dorsalis pedis artery is present. Type 2B, only the plantar arteries are patent. In type 3, with both the dorsalis pedis and the plantar arteries occluded and only seeing collaterals here. So we're wanting to look at these outcomes. We see these clinical outcomes of pedal artery angioplasty for patients that had ischemic wounds. This is a paper that was pulled from the multi-center rendezvous registry, and this rendezvous study wanted to investigate clinical outcomes of pedal artery angioplasty. And they had 257 consecutive patients who had critical limb ischemia, and 140 of these went on to have plasty. They showed that this intervention helped heal wounds with patients who had inframalleolar disease. Now you can see that while yes, it is a difference, you can see that the time, the rate in wound healing really at best wasn't the greatest. It was 60% at 1 year. Now that's the goal here, just to get the wounds healed, because if you see that patients who didn't have this intervention, their success of healing wound was only about 38%. And we see that the wounds did heal faster in patients who had the intervention, 211 versus 65 days. Predictors that showed delayed healing was a non-ambulatory status, a wound depth greater than a UT2 in those who were on hemodialysis. Tsubakimoto in endovascular therapy in 2020 looked at another paper from this rendezvous registry, and they're looking at the outcomes of pedal artery angioplasty, showed they're independent of the severity of the inframalleolar disease. Now, keep in mind the different Cairo classifications we talked about earlier. And they had the 257 limbs with the inframalleolar disease, and they broke it down into moderate disease, or a type 2 Cairo, and severe disease, type 3, with 144 and 113 limbs, respectively. They showed that wound healing was higher in the angioplasty versus the no pedal artery angioplasty group, regardless of the severity of the disease the patient came in with. Roughly 60% versus about 35 to 40% in these type 2 and 3. Overall success of pedal artery angioplasty was 88%, with moderate and severe being pretty much the same at 89 and 88%. And there was no overall effect by severity of inframalleolar disease. You can see this depicted graphically here, where you can see the type 2 on the left and the type 3 by Cairo classification, showing the wound healing rates. If you had the intervention, you had about a 60% chance of healing at 1 year. If you did not, it was 40% in a type 2, 35% or 34% in a type 3. Mohapatra in 2018 in JVS looked at bypass versus endovascular intervention for healing ischemic foot wounds secondary to tibial artery disease. They had 417 patients, included 105 in the bypass group with 312 in the endovascular intervention. This is a retrospective chart review with the primary outcome being wound healing. Now, they did have a mean follow-up of 25 months for bypass and 20 months for endovascular. And they showed that the overall wound healing rate was about 45-46%. Healing was better in the endovascular group, but survival improved in the bypass group. And major amputation-free survival favored bypass, while there was no difference in minor amputation in these groups. Now, this is a big topic to cover. I thank you for your time today and your attention. I hope you have a great rest of the conference, and once again, thank you for having me here today.